Early and accurate diagnosis of malaria is crucial for effective treatment and management of the disease. Here are various methods used for diagnosing malaria. Medical history. The doctor will take a detailed medical history including the symptoms, travel history, and exposure to mosquito bite. Physical examination. The doctor will conduct physical examination to check for the signs of malaria such as anemia, which can be detected on physical examination by looking for the signs of pallor such as pale skin and conjunctiva. Enlarged spleen and liver, which can be detected on physical examination by palpation of the abdomen. Neurological symptoms, which can occur in severe cases of malaria and include confusion, seizures, and coma. However, blood tests are the most common way to diagnose malaria. These include microscopic examination of the blood smears using both thick and thin Giemsa stain smears, in which a sample of blood is taken and examined under a microscope to look for the presence of Plasmodium parasite. This is the gold standard test for malarial diagnosis. The Giemsa stain is a combination of eosin and methylene blue dyes that selectively stain certain components of the cells and microorganisms, making them visible under the microscope. Thick film is used to detect the presence of parasites because they examine a larger sample of blood, but they can detach from the slides during staining. Thick smears also diminish the amount of light that can pass through, making it difficult to visualize the morphology. However, thick smears are more sensitive than thin smears and can detect very low levels of parasitemia, although its specificity is low. Thin film is used for identification of species of the parasite. Species identification is important because treatment of different species is different. Thin smears is also used to quantify the parasitic load, and if more than 5% of the RBCs are parasitized, the diagnosis is usually Plasmodium falciparum malaria. When the Plasmodium parasite infects the RBCs, it digests the hemoglobin and releases toxic heme molecules, which are then converted into hemozoin. Hemozoin can be detected in the blood using the hemozoin detection test. Plasmodium vivax and Plasmodium ovale RBCs contain Schuffner's dot, which are intracytoplasmic granules that stain red using the Romanowsky stain. Rapid diagnostic tests are simple rapid tests that can be done on site. These tests detect specific malarial antigens in the blood and can provide results within 15 to 20 minutes. PCR can detect the genetic material of the Plasmodium parasite. This test is very sensitive and can detect low levels of parasite. PCR is used when the blood smears do not reveal the diagnosis. In some cases, additional tests may be needed to confirm the diagnosis or to check for the complications of malaria. These may include tests to check for anemia, liver or kidney function tests, and chest x-rays. Now let's talk about the treatment of malaria. Chloroquine is the drug of choice for the treatment of uncomplicated malaria caused by non-falciparum species and in areas without chloroquine resistance. This drug, however, doesn't kill the hypnozoites of Plasmodium vivax and Plasmodium ovale. These are killed by primaquine, hence preventing the relapses. Primaquine should not be given in G6PD deficient people. Primaquine is metabolized in the liver to several metabolites, one of which can oxidize hemoglobin in the red blood cells. In people with G6PD deficiency, the reduced ability to neutralize the oxidative stress caused by the primaquine leads to severe hemolysis. Uncomplicated chloroquine-resistant Plasmodium falciparum infection is treated with either coartem, which is a combination of artemether and lumefantrine, or malarone, which is a combination of atovaquone and progonil. In severe complicated cases of chloroquine-resistant falciparum malaria, IV administration of artesunate or quinidine is used. Chemoprophylaxis of malaria for travelers to areas of high chloroquine resistance include mefloquine, doxycycline, or malarone. Whereas in low chloroquine resistance areas, Chloroquine and progonil is given, which is started 1 week before and continued until 4 weeks after travel. This ends our discussion on malaria. Hope you liked the video. Thanks for watching.